another episode of our 13-week educational series on transforming physical therapy with diagnostics. We are anticipating this program to help you elevate and your patient outcomes, expand your services, and thrive in a changing physical therapy landscape. And before I talk and present today's guest and the topic, I want to remind you all that you should be subscribing to our weekly podcast, Your Practice, Your Money, where clinical success meets financial freedom, and make sure that you not only subscribe in any of the platforms that you like to hear podcasts like Spotify, YouTube, or Apple Podcasts, but also go to our website, yourpracticeyourmoney.com, because we have a lot of resources there which you will find very helpful. I also want to remind you that this 13-week educational series not only helps you to learn significant information about how to establish diagnostic testing in your practice, but also provides you with 10 to 14 CEUs for attending our 13-week program, and that is dependent on your state. That is really very valuable to for many PTs. All right, so I am today very honored to present my guest, who is a very good friend, a distinguished physical therapist, and also an educator in manual physical therapy, who has actually developed his own manual therapy program and platform, but also is board certified in clinical electrodiagnosis, in clinical electrophysiology testing, and someone who achieved his certification undergoing through the hands-on diagnostics program. So he is really the right person to have a discussion about not only electrodiagnostics, but how we can utilize the power of electrodiagnostics in implementing more appropriate manual therapy treatment plans for our patients. And I want to welcome Dr. Daniel Neff in today's program. Dan, thank you so much for joining us.
I'm humbled to be in your presence. Thank you.
Thank you. And I want to first ask you the question and start with, you have been doing manual therapy for many years. You developed your own program, which you teach across the country, many practices in manual physical therapy, a very effective program, actually. But tell me first, what intrigued you in getting involved in electrodiagnostics to begin with?
Oh, I'm not sure you're going to like this answer.
I like the truth.
So I was doing a sports clinic with a local orthopedic, and we were doing musculoskeletal ultrasound. So essentially, these athletes would come in. It was a sports clinic. Athletes would come in. I'd do an orthopedic exam, and the physician would do musculoskeletal ultrasound. And then, depending on what we saw, then I would go ahead and treat that patient like right away with some hands-on spinal mobilization. we'd get the athlete back onto the field super quick. So very busy. We had a good sports clinic going, and then all of a sudden he stopped practicing. So we live in a small town. So I was like, all right, like who's going to do musculoskeletal ultrasound for these athletes now? So, of course, we were like, well, we're going to do it. We're going to take care of the community.
Of
So,
course.
I had met you, Demi, I think in Denver we were together, and you started telling me about this, and Electrodiagnostics was linked with our desire to do musculoskeletal ultrasound. So here we are now.
It's awesome. That's fantastic. And tell me, um, how, and we'll talk about more specifics, but generally, how did your involvement in electrodiagnostics journey through becoming board certified and now as a board certified individual, part of the mentorship also program of HUDs, this has changed the way you practice manual therapy. And actually, I have to say that you went all in because you not only trained yourself, you trained literally your top team, all three of you guys. And I have to applaud you that three members of his top team, they all joined together the program and they all got board certified at the same time. This is like truly spectacular that you guys achieved. But how has it affected the practicing of manual therapy for your patients?
So the goal of our practice, and I know it aligns with your goal, and that's why I enjoy working together with the HODS organization, is to enhance the practice of physical therapy, to create an atmosphere where we are held in the highest regard. We are the first choice when patients have a muscle, joint, nerve injury. But to do that, we have to get patients better. And we have to get patients better on a consistent basis. There can't be just a good, practice here and a good practice there. Like we have to build our reputation up as a community. So the educational process that we went through with HODS is a different skill set than we got in physical therapy. It's I want to say it's close, but it's really not even close. Like the things that we learned through the HODS education and through being ECS certified has elevated our ability to treat these patients because essentially our whole system is based off of neural identification. We trace back where that painful segment is coming from to the spine, and we treat that segment to start with. So for us to be able to understand where the origin of that patient's pain is coming from with an electrodiagnostic test just has like sent our outcomes, sent our treatment plans, everything kind of through the roof. So it has really paired well with our spinal mobilization system.
So describe to me what happens. Let's say, and I think I want to make sure that we all understand that what sounds for you and me elementary because we are doing it every day, for some of the people who are watching or listening, that they have not practiced that, the combination of electrodiagnostics and manual therapy, the whole concept may sound a little foreign to them. Let's suppose that I come into the practice and I come in with, and I complain of some pain in my neck, um, radiating to the arm, to the left arm, let's say, and I have also some on and off numbness and tingling in my fingers. Okay, so that is how I present to the practice. So when that patient walks in to your office, what would be the steps that this patient will undergo?
So again, going back to our philosophical approach, which is to elevate the profession. So for us, it's a uh, it's a clinical care issue. So we educate all of our practitioners that it is very, very important. If we are going to move toward being primary care physical therapists, we have to make appropriate referrals. So understanding that that patient that you just described comes in, we need to know right away what's going on with that patient. All right, let's say, for example, that patient comes in, they're having numbness and tingling, you said left hand, numbness and tingling in digits 1 through 3, right? So, but they also have pain that's radiating down the outside of their arm and, their volar forearm. So essentially, we want to know what's going on with that patient. So that patient is going to get referred for an EMG immediately. Because what we don't want in our profession is to hold that patient for 30 visits and then all of a sudden say, oh, okay, you let's do the EMG now. We see denervating potentials, in that patient, and now that patient has to have surgery because we didn't fix them, we didn't change them. So essentially that patient's going to come in, they're going to have an EMG right away. So let's say, for example, we see that patient and we do an EMG and we see that it's a denervating cervical radiculopathy coming from C6. But the thing that Electrodiagnostics has changed for us is that second issue that they have. They also have a superimposed carpal tunnel as well, right? So these double crush injuries we've been able to heal much better because, all right, so now that patient comes in, we're going to treat them. We're going to focus on that C6, C7 level. We're going to go do spinal mobilizations to the neural structures in their spine. We're going to do neural remodeling with them, as well as we're going to go to every joint in their hand. We're going to manipulate the radiocarpal joint. We're going to manipulate the elbow. We're going to do neural tension type techniques with that patient. So the electrodiagnostic allows us to be very specific where we're going to, but it also helps us not to miss especially those double crush type things, which before we came in with HODs, we would absolutely be treating that patient as a C6, C7, but we would probably miss this double crush injury without ECS testing.
And because number one, not necessarily every person will be symptomatic in the exact distribution of median nerve. Number two, the sensitivities of the most popular, let's say, carpal tunnel tests, Phelan sentinels, they vary from high 21% to 50%, and lots of this stuff can be missed just with a clinical examination. So what improvement have you seen in outcomes, right? For example, we say we share with people, and actually let's make sure that we're going to put this study in the resources of this episode. We're going to put our 2000 published study in the resources of this episode that demonstrates 61% improved outcomes from the on those patients who did receive EMG studies. But tell me, have you seen improved outcomes in your practice?
So not only, do we get resolution of symptoms, I think in part humbly because of our techniques that we utilize, but we have also seen like literally neural changes in that patient because a lot of patients, what we'll do is, especially if they have significant numbness and tingling and paresthesia, we'll go back, a month later and then we'll retest that patient. So we have a baseline EMG done on that patient and we'll go back and look, is it gone? Is the lesion gone? Is the slowing process gone? So we've seen tremendous outcomes in that realm where we go back and there's like literally the slowing has disappeared on that patient. They have normal values now. But the ability to, and you brought up not to just talk clinical on this, but doing this now for a number of years, like you have that patient who has a very severe median neuropathy at the wrist, like Tinel's, you would think Tinel's would be positive, Fallon's, Durkin's, all that stuff. Like if that nerve's gone, like the tests aren't there, you're going to miss it just doing a clinical exam on that patient. So to be able to go in there and see that it's and it's the outcomes have been tremendous because we can go directly to the origin of the problem. But the other thing that it helps us with is it builds our medical reputation in the community because let's say, for example, that patient does have like denervating potentials, that are coming from their spine. We see that patient for 6 visits and we make no gains with that patient. Like they're still having severe pain. Like we are starting that referral process right now. Now, we're not discharging that patient and saying, hey, we can't do anything for you, but we are managing that patient. We are starting the referral process because, if it gets to 8, 10 visits and they're still no better, like we're going to get that patient back anyway after surgery. Like we need to manage that patient. So our referrals are so much better. So I think our medical reputation in the community, not only with the patient, but with these other providers, they're like, man, they're making appropriate referrals to us. So that I can't even describe the reputation that we have been able to increase through electrodiagnostic testing.
And I'll tell you, I totally share exactly what you're saying, and many also of the HUD's members, they testify of the same thing, that because this approach builds such a great reputation in the communities, sometimes there are patients who will travel 50 miles away to come and get like the right evaluation and right treatment because of the reputation that you build. Um, I know that you brought with you, and I'm not sure if Becca will show them or I project them myself, some uh, case studies from a patient or two, and that would be awesome if we put that on the screen, so we can discuss it a little bit and tell us, explain like what people see here as if we are, I'm not going to say 3-year-olds. I'm going to say as if we are 7-year-olds.
Okay,
Okay. So break it down, make it easy for us.
I got you. Thank you, Becca, for your skills. So this patient came to us. She was middle-aged, younger patient, 33 years old, fell onto her left elbow on her kitchen floor, hit it on the tile on the medial side, the inside of her elbow, and presented to us with numbness and tingling in her left hand digits 4 and 5. So the last 2 fingers were going numb. So she had it for about a year before she sought any treatment. So we did an EMG on her pretty much immediately when she came in. And as you can see in the red, I did an EMG last year on her in July of 24. And if you can you see my cursor there or no?
Uh, Not really.
Okay, thank you, thank you. So if you can look, so we tested her off of the ADM, owner innervated muscle, and we looked at the slowing across her elbow, and you can see that above the elbow, when we stimulated that segment, she had slowing that was not only normative. It wasn't over 43 meters per second, but it also was slow comparable to the below elbow segment. So then we said, okay, let's make sure that this patient has this. So we tested on her FDI, so also owner innervated, and we basically did the same stimulation sites. And you can see that it confirmed slowing across her elbow. So I did what's called owner inching, where is a more sensitive test where we just move in small segments around the elbow to see where it is slowed at, in case we would have to send this patient for a surgical consultation. So Becca, could you go one slide forward? Yeah. Yep. So you can see, so I owner inched her again in July of 24, the same study, and it showed that there was slowing approximately 2 point between her medial epicondyle, the bone on the inside of her elbow, to about 2.5 centimeters above the elbow. And that's what we call the retroepicondylar groove. So essentially what happened was then I treated her for essentially 8 visits. I saw her for approximately 1 month. So we went to C8 T1 levels in her spine, mobilized those levels. We also fixed a first rib dysfunction that she had on the left side. So anytime that we take a fall onto an outstretched arm, those ground forces come up through our arm, through our clavicle, and can affect the first rib. So we get a first rib dysfunction. Well, the lower trunk of the brachial plexus, the group of nerves that comes out of our neck, lays right on top of the first rib. So that lower trunk is that C8T1 innervation that essentially tells the owner nerve what to do. So we fixed our first rib dysfunction. We mobilized our CT junction, C8T1, nerve root level. Then we went distally. We did elbow mobilizations. We did humeral ulnar, humeral radial. We went distally to the wrist. We even mobilized the carpal bones, all the phalangeal joints, just to stimulate the neural system in her. So I saw her for 8 visits, complete resolution of symptoms. Could you go back to that then? Back to that.
Before she goes back, can you
Yeah.
pinpoint on your body one more time the areas that you worked on here, just because so for people to just
Yeah.
see that one more time?
So guys, we're like nerve experts now, thanks to HODS, right? So trace the painful or dysfunctional segment back to the spine. So we're looking at ulnar nerve C8T1 innervation. So we did mobilizations to her cervical spine, C7, T1. We worked on the neural structures at 8 and 1. We did spinal mobilizations. We fixed her first rib dysfunction. She also had some other rib dysfunctions moving lower that we mobilized. We mobilized her humeral ulnar joint. We mobilized her radiohumeral joint. We mobilized proximal humeral radial joint. We mobilized distal ulnar radial joint. We mobilized her carpal bones. We even mobilized the phalangeal. because what happens is with this patient, right, she's had it for a year. So why hasn't it healed? Why did we get her better? So this proximal segment, this brachial plexus, lower trunk that was being irritated by this first rib dysfunction was not allowing the neural healing to get down there. So we clear out the mechanical dysfunction. The neural structure is no longer irritated. It heals, sends everything distally down to it. Complete resolution of symptoms. There's no longer any stretch. There's no longer any dysfunction that goes across the elbow now.
Awesome.
Okay.
So we'll reshare now. Let's go back to the previous slide.
Yeah, one more back. So then you can see it was almost exactly a month later that I retested her. And if you look at the above elbow segment from 8/20/24, it's back to completely normal again. So the speeds are normal. So we tested it off. That was off the ADM, ulnar innervated muscle in her hand. And then we also retested the FDI, and you can see her speeds have returned to normal. There was no slowing there. And
This is fantastic here because you can see really like uh, directly before and after, which is absolutely amazing. On July 23rd, you have it. You have the pathology. On August 20th, pathology gone. And you know that this is the direct effect of your amazing manual therapy treatment. I mean, my goodness, the proof is in the pudding. Unbelievable. So that's
yeah, it was
awesome.
cool. Even if you go one more slide, you can see too, also there was no slowing when we did a much more sensitive test, the ulnar inching. So yeah, it is pretty cool study.
Dan, can you, let's suppose that this patient was a surgical patient. And I'm going to ask you, Becca, to go back to that slide. Let's share that slide for a moment. Let's suppose that this was a surgical patient, right? Can you talk a little bit about if it was a surgical patient, what would be the value of doing this inching technique
Yeah.
in a patient who is supposed to go for surgery, and how you can help the surgeon and how valuable you are to the surgeon, and perhaps you know what, let's stop the sharing for a moment so that you can describe it. You can describe the technique on your body maybe so people can kind of understand it.
Yeah, so we've all kind of seen these surgeries that have, a 10 centimeter incision that goes essentially from the proximal 1/3 of the forearm up, to their distal tricep, right? It's the whole area that they open these patients up. So when we do these more sensitive tests, we're able to localize where the slowing is occurring with that patient, whether it's, the fibers are getting blocked or there's just some sort of irritation at that level, that maybe it's getting compressed against the bone, but that's the segment where they're going. So these surgeons will go in then, and the outcome for the patient is much better. It's a quicker recovery because the incision then is only from the, approximately the medial epicondyle here on our elbow to, maybe 3 centimeters. So, maybe they have a 3.5 centimeter incision instead of a 10 where they're trying to localize it themselves. So the outcomes are much better. They recover quicker, and the surgeon appreciates the fact that, hey, it takes them much less time to be able to do the surgery when we can localize it for them.
And what feedback have you received from both surgeons or patients about your ability to help them recover faster or be more effective in terms of your treatments?
Yeah, so, and I say this in the most humblest way possible and the most easy way for our profession, but so I get to spend a lot of time with physicians. And I was hanging out with this rheumatologist the other day, and this guy is like so smart. Like I can't even imagine being as smart as he is. So he's having a discussion with another rheumatologist who has RA. And so essentially what happens is they're discussing how the medications, when you change a class of medications, it changes all these different functions within our body, right? So I'm sitting there listening to it. It was very interesting, but not in our wheelhouse, right? So he introduced me and he's like, hey, this is, about halfway through the conversation. He's like, hey, this is Dr. Neff. He's my guest today. And he's like, he's a physical therapist. And the other rheumatologist, the patient just like keeps talking. And then he goes, he does EMGs for us. And the guy like stops and he like turns around and he goes, oh, you do EMGs, right? And like we had like a 5 or 10 minute conversation then. And I was just like, oh man, like we got some work to do, but the elevation uh of your reputation when you are able to attain these skills is I I can't even explain what we've done, been able to do with this skill set. But to answer your question, so we have, now we have these surgeons coming up to us asking us questions like, should I do surgery on this patient? Right? Hey, I did surgery on this patient. Why didn't this patient get better? And it's like, hey, man, he's got like a polyneuropathy. Like it's not just at his wrist, like his whole nerve is gone. So, cutting him open at the wrist isn't going to help. So it's opened up another realm of communication with these surgeons that we just don't get in the strictly in the physical therapy realm.
Awesome. And Dan, y- you as a practice owner, what do you see as the difference for staff members who get trained and potentially see that as a career opportunity?
It's funny because uh, so we have two students coming in next year who only want to do an EMG rotation with us,
It's awesome.
right? And
That's
I
awesome.
was like, how? Like local school called us up and said, hey, we have a student that wants to get into EMG. And I said to him, I said, like how did you get this? Like how did you like get this thought process that you want to do EMGs? He's like, I Googled like who makes the most money as a physical therapist, and they were like ECS certified guys do. So I was like, that's smart. That's smart. So they're coming do rotations with us. The staff members overall who have gone through this, and you mentioned that we had a number of staff who are now ECS certified. Just the level of um, practice that they have and the reputations that they're building in the communities that they serve um, just continues to elevate, on a weekly, monthly, yearly basis. So it definitely motivates. And honestly, like this isn't something that you can just do and forget about. Like this is a lifestyle change that, you know, you got to be on your game every single day. So when you talk about being elevated in your practice and knowing what you're doing, and I'm saying this super humbly, like these guys are studying, on their off days. They send me Snapchats when they're at the beach of Preston Shapiro books that they're reading, like they're just like motivated to continue to have conversations with surgeons, be able to fix people who have difficult conditions, be able to diagnose and manage patients and hold our company, our profession to a higher level.
And I don't want to embarrass you, but it would be an omission if I did not show here that this past year at the HADS Symposium, you and your team received the Practice of the Year award. And here you are guys just enjoying the moment and being respected by your colleagues and really celebrating the impact you guys are creating for your communities and your patients. Tell me a little bit about the financial impact that implementing something like this can have for a practice.
So, initially it's like anything else. So, you have to make an investment in things that you think are going to be fruitful. And we've made good investments, we made bad investments, through our time owning a physical therapy practice. But, this is one of those ones that just like stands out. Like, was it hard? Yes. Was it difficult? Was it trying to get through? Yes. But, if you ask me, would I do it again in a second, I would, pay whatever you asked us to do. If I knew what I knew now, the finances would not be a concern because, we're at the point now where we've learned through our mistakes. We're, been mentored well. We're providing good studies, and physicians are like knocking at our door for us to come out and do studies for them. Like it's an easy sell. Like it's so difficult for hand surgeons, uh, any surgeon in general, to get an EMG. So when you walk into that office and say, "Hey, we can solve your problems. We'll do your EMGs for you so that within 24 to 48 hours, you're going to have the report. You can schedule that patient for surgery like immediately. It's not going to be 6 months." We're in a group now where they were like, "Yeah, we sent them out for an EMG, and then the hospital kept them and did the surgery on them." So it's a no-brainer to be able to go in there. And some of the prices that we're able to now command, being able and confident in our skills and doing good exams, uh, has been tremendous for our financial, solidarity in our finances, in our clinic, and being able to purchase new equipment. Like it's definitely worthwhile, and I would do it again in a heartbeat.
That's awesome, Dan. And how do you see the future of diagnostics evolving within outpatient physical therapy?
So I would hope that it would go this way. Like starting out this process was like, oh my gosh, like, are we going to be able to make it through this? And, you know, I mean, just trying to run a practice and do the things that you're asking us to do. But, when we talk about elevating our practice and putting ourselves into a position where we are primary care, practitioners, where we're seeing those and gaining a medical reputation where we are held in the highest regard. Like, I don't see a better, I don't see a better way to do it than to keep moving forward with this. Like the reputation that has, kind of tagged along with this has been great for our practice, great for, I think our profession in general.
Thank you. And look, you are an educator and you deal with a lot of younger PTs also. what advice could you give them, to those who want to stand out clinically, but also financially? Because younger PTs, they walk out from their universities with huge loans, student loans, and with a reimbursement landscape that it's not really that optimal right now. So what advice can you give them if they want to stand out both clinically but also financially?
Yeah, and all due respect to our DPT degrees and our physical therapists and CAPD, like it's a great program that we go through. But this is a different skill set. And the biggest advice that I would uh, tell young physical therapists is why are you doing this? Like, are you just doing it to try to, make a good living, or do you actually really want to be good at what you do? Do you want to be able to diagnose patients? Do you want to be able to say, have patients in your community go, I'm going nowhere else than to, Dr. Kostopoulos. Like that's all like that's where I'm going. I'm not going to see anybody else. And to do that, it takes work. It takes a grind, but getting into the electrodiagnostic field is something that you should absolutely consider. If you're willing to go through the grind and do it, like you are going to be elevated in your community. I don't think you have a chance, like not to be. That would be the biggest, piece of advice that I would give somebody is like really, soul search. Like, what do you want to do? Like, you just want to go to work every day, for 6 or 8 hours and go home? Like, you're probably not the person to get into this. But if you truly want to be respected, you want to be held high, elevate your profession, like this is the program to go through.
Thank you so much. And I will open it to any questions that anyone might have. And those of you who are right now watching, you can just chat your question. Oh, there is already a question here. Um, oh, it says, Dr. Neff, if I could ask a question, how much this has increased your private practice business? That's the question we have.
Yeah. So the cool thing about this is now we have hospital-based physicians who are sending us patients to do an EMG on. Patients and physicians that we would never have access to before being a private practice owner. So the amount of patients that it opens us up to has been tremendous. I can't tell you. So in our Willow Street clinic, Willow Street, Pennsylvania, I do most of my EMGs out there. They are so busy at that clinic, they don't even know what to do because if a patient comes back and they don't have some sort of not demyelinating, like some sort of condition where it's denervating the nerve and potentially they may need surgery. I give that patient a card and say, hey, if you guys decide to go to, because most of the time they ask me, what should I do? Right? Okay, if you're asking me, this is what I would do if you were in my family. I'd let one of our doctors take a look at you. So they're so busy from the referrals that I just give them, as well as having access to physicians that we would never have access to before, like a hospital referral, unless like it's their family member or them that are hurt, like they're not allowed to refer outside of that. So the access that we've had has been tremendous to different physicians and patients.
And I want to vouch for that, and also I want to add to that you guys know that our local Dan is in Pennsylvania. We are in New York. Um, I'll give you some names: NYU Langone, New York Presbyterian, Columbia Medical Center, Montefiore Medical Center, Maimonides Medical Center. Those are names of hospital systems that are very well known across the nation. Week in, week out, we receive referrals specific to EMG testing, more than 150 referrals per month from these medical centers. Why? Because number one, we provide quality testing. Number two, we provide much faster access where their patients do not have to wait months to get a test. We can get the test within 48 hours. And this is our big promotion. You know, within 48 hours, we can get the test done. Within 48 hours, we provide you the testing results. And that makes a huge difference. We do have some other questions. Let's see. I'm gonna take a question from Facebook. Actually, we have right now from Tim. So he is watching. Are financial options valuable to some therapists? Are there financing options valuable to some therapists who want to get involved? Yes, absolutely. Actually, our organization has we are working with financing organizations, so you don't have to go to a bank to get a loan. You can go directly to the financing organizations that we can recommend you to, where they know exactly the product we deliver, they know exactly your needs, and they can provide you an extremely competitive rate and very quickly. So you can reach out to us on that. Are you using the Cadwell system, EMG, NCS, and MSK US combined system? I mean, Dan, you can answer for your practice, and then I can give a general answer to that.
So personally for us, no. We use the Cadwell system and the Preserve through the HODS organization for our EMG studies. And we use a different unit for our musculoskeletal ultrasound. We did try the combined unit just because we wanted to make it easier for report writing, but honestly, the quality wasn't the same as the other unit.
Understood. And I will say that in general, from the HUD's universe of people, yeah, there are a few people who are utilizing the combined unit, but I would say the vast majority of people, including our local practice, we use separate units for EMG nerve conduction and separate unit for the MSK ultrasound. We work with various companies, Asaote, Sonosite, Butterfly, Lumify, Philips, Minolta. You know, there are many, many different companies. Let me see if there are any other questions. I see here. Okay. Well, Dan, any final words before I close?
Just something that we've done this year, maybe for to help some practitioners out. So one of the things that we've done is we've taken an aggressive approach toward referrals. So we track every practitioner in our office. We track their referrals to specialists. So I went this year at the beginning of this year, for example, and I went to this orthopedic group and I sat down with them, and essentially I said, hey, here are the numbers. We referred over 100 patients directly to you for either surgery or pain management. Here are the numbers that you referred back to us. Honestly, we're considering referring these patients somewhere else, someone that'll work, with us back and forth. And like referrals changed immediately overall. So, tracking these referrals and making appropriate referrals can not only increase your medical reputation in your community, but also you can, as an owner, start leveraging your physical therapy practice as well.
Thank
But
you, Dan.
no, I mean, thank you for having me on. Like it's always an honor to be in your presence and Hod's, and I appreciate it.
And I have to say that those of you who want to see eh, close up and in action, Dr. Neff, he will definitely be presenting at our HUD symposium coming up in October. And most likely we're going to be presenting also at the CSM next year. Well, that brings us to the end of today's episode. Um, uh, and a sincere thank you to Dr. Dan Neff for shedding light on how EMG testing is not just a diagnostic tool. It's a patient management strategy that elevates your care, enhances your clinical decision making, and strengthens your business model also. Um, so if you are ready to move beyond guesswork and bring precision into your practice, now is the time to consider EMG testing training, whether you are looking to improve outcomes, increase your value in the referral network, or unlock new revenue streams. Diagnostics can be the differentiator for you and your practice. So for more tools, training, and resources on how to successfully implement EMG and other diagnostics, visit a few websites: diagnosticsforpt.com, handsondiagnostics.com, our podcast website, yourpracticeyourmoney.com, and this program's website, which is discoverdiagnostics.com. So make sure to go in all these websites, subscribe, leave us a review, and we'll see you next week for another impactful episode designed to help you grow both your practice and your profits. Until next time, I'm Dr. Dimitrios Kostopoulos, and have a good evening.